Hello, listeners. Welcome to Views on Health. And as yet another Monday evening comes by, it's a great pleasure to have with me on the program tonight Dr. Gayan Bandara, consultant vascular and transplant surgeon at the National Hospital of Sri Lanka. A warm welcome to our studios and to SLBC. Doctor, I'm sure it's going to be interesting to speak with you on the topic that you've chosen, which is diabetic ulcers. Without any further ado, could you tell us for a start, how common are diabetic ulcers, considering that diabetes is rampant in Sri Lanka?
Yeah, so thanks for having me for this interesting discussion. And diabetes, as we all know, is a global epidemic. And in general, around 10% of the world population is affected with diabetic. But according to the latest studies we have in Sri Lanka, around 30 to 40% people are affected with diabetic, but yet more than 40% of people are not diagnosed or not in proper treatment. So the diabetic ulcer is very common in the Sri Lankan population because they are poor diabetic control and they have already complicated diabetic foot.
So doctor, when you say diabetic ulcers, where do these ulcers appear on a person? Body.
So the ulcer may basically in diabetic, as the word say, diabetic foot. So mainly diabetic people will get ulcer in their foot because of the multiple reason. One reason is because of the walking and everything. The foot is the one which can get the hit or some damages due to pressure and everything. So other thing is there are several mechanisms in diabetic why people get ulcer. Depending on that, there are multiple pathophysiology why diabetic people get ulcer. Generally, they can have usually in the toes and the sole and anywhere in the foot.
But does it mean that they won't have in other parts of the body? Can it happen in maybe the hand, the face, anywhere else? For any reason, it can also happen?
Yeah, anywhere in the body they can get ulcer because of their lack of immunity, the poor immunity in their body. So when usually a normal person, when they get a small scratch or cut, they tend to heal. But in diabetic patient, because of the poor immunity and that means poor healing process, they can get infected and can get complicated. So anywhere in the body they can get ulcer, but in general the ulcer is more common in foot.
So now when this happens, obviously doctors advise the patients to look out for these injuries.
Yeah.
Maybe there might be some sort of a lesion, they might cut themselves, or there can be another sort of injury by tripping on something, or maybe a rough surface, and then the skin can break.
Yeah.
So from that point onwards, doctor, is the point I would think as a lay person, a patient has to be careful.
Yeah.
Correct me if I'm wrong, because you're the
you are
expert,
exactly
not me.
correct, yes.
So going from there, what would you tell your patients to do if such a thing happens? First thing what they need to do, because it can happen not when they are with you, but when they're in their homes or in their office or wherever they are.
Yeah.
Maybe they're going for a walk.
Yeah.
And they may be even in shoes, but still, that doesn't mean that any injury can't happen.
Yeah.
I mean, even with walking shoes.
Yeah.
Could you explain that?
Yeah, especially when you consider, when you tell like that, I remember this, we have diabetic patient has a condition called diabetic neuropathy. When a diabetic is getting worsened and not properly controlled, their nerves get involved. So usually when we keep our foot on a sharp object or stone or some heated object, we have a protective sensation. So we get reflexly we get our foot back. But when they lose their protective sensation, they don't feel whether there's an injury or not. Then on top of that, they have lack of proper immunity, and on top of that, they get the advanced infection that they don't know it. So that is the main reason why diabetic people, they should be aware whatever happened to their foot, they should be having a proper look. We usually advise them, every diabetic patient, to have at your foot at least once in a week. So we ask one of family members to have a look, or unless they can have a mirror in front of you and keep and check properly whether there's any ulcer, especially in the sole.
So that's a good way of checking,
Yes.
even if there's no injury, whether the skin is normal or is something happening without your knowledge.
Yeah, exactly. Because if they have a diabetic neuropathy, that lack of sensation, they don't feel there's a wound. They don't know. But they only come after they getting infected and complicated. When the sepsis is overwhelming, only they know there's something wrong. Then only sometimes they see their foot, and then only they notice there's a severe infection going on. Until that, they don't know because of the lack of sensation.
So, doctor, you said a while ago that 30 to 40% of the population is considered as being diabetic.
Yeah.
And still you don't know about the rest of the population. There may be more. The percentage may be higher.
Yeah.
Now, again, what we have heard is that even children today are diabetic. Maybe not as many as adults, but there are children too who are diabetic.
Yeah.
So are they also under the same risk of getting ulcers or some sort of, if an injury does happen to them, especially children when they play?
Yeah.
They are young, and the tendency is to play. And in such situations, if they have a fall or they hurt themselves, they hurt their knee if they fall.
Yeah.
The knee, they could be in shoes, but the knee could be exposed.
Yeah.
Or the elbows, any part of the
Yeah.
arm. So in that situation, even is that wound something to take quick notice of?
Yeah. So as diabetic is getting a global point endemic in Sri Lanka, so according to the NIVA study, is generally 30 to 40%, or diagnosed and undiagnosed both together. But due to poor food habits and lack of exercises, and the age that who are getting diabetic is getting younger and younger also. So anyone who is having diabetic, if they have a poor control, they have a higher chance of getting complication if there's a wound. Generally, when a small kid had a small abrasion, because they have a good healing capacity compared to the adult, so usually it get healed quickly. If there's any suspicion that the wound is not getting healed properly, so every physician or clinician would think there could be something wrong with this patient, a child. So they definitely check about her fasting blood sugar and the sugar status, whether he's diabetic or any other condition why wound is not healing. And especially if the patient is already diagnosed to have diabetic, they should have been properly instructed that if there's a body injury anywhere in your body, there's a high chance it get complicated, and they need to seek medical advice sooner rather than waiting until it gets healed.
Thank you, doctor. Now, how treatable is this? Can the wounds be cured, or in certain cases you cannot?
Very good question. So, in general, the wound can be healed if you properly identify and properly manage the wound. So, when especially diabetic, the most difficult part is controlling the infection, because they have lack of immunity. So just that is why we need to have a proper education to everyone to identify early wounds and refer to appropriate specialist or appropriate clinician to treat at the beginning, rather than it getting late and come to a station that you can't salvage that limb. The main concern in diabetic foot is the foot leg amputation. Initially start with the toe amputation, then the foot amputation. Later it can go to a major limb amputation because we can't salvage the limb. So it's treatable, and it's treatable from the day you diagnose diabetic. So proper diabetic control is the first step. First, we prevent having an ulcer. Then if there's an ulcer, then we have to have a proper pathway to identify early lesion and treat at that time. But unfortunately, most of the patients come in the intermediate or late stages to appropriate specialist and all that. Then at that time we have to treat the current situation. If there's infection, we have to treat, do a wound debridement, clean the infection, and give him or her good antibiotic to control the infection. After that, depending on the degree of tissue loss, we consider what further treatment is needed for that patient. It is customized plan for every patient, and especially tight diabetic control is a key.
Now, doctor, when you talk of treating through surgery, when you talk of amputation, now, if the injury or the ulcer can be treated with medication, whether it's antibiotics plus any applications that you think would be appropriate.
Yeah.
And it heals, then it's done. But then it can always recur in different ways.
Yeah.
To come down to the surgical part where it's necessary to amputate.
Yeah.
And you spoke of amputating first the toe, maybe 2 toes, whatever, and then you go on to, it extends onto that particular leg.
Yeah.
A question, can a person have both legs affected?
Yes, definitely. So diabetic is a systemic disease, so it affects generally entire body. So it affects whole your body immunity, and neuropathy is systemic, and it usually affect the both limb. So if a patient having a one ulcer in one leg, there's a high chance that they have another ulcer in other foot recently in near future because of the general overall conditions.
So at what point do you decide that amputation is necessary? What are the signs, for example, just for us to know?
So as a clinician, we always try to avoid amputation. That is our main target, to avoid amputation. So that is why we need to identify early lesion and check whether there is a infection going on. In infection, there are several stages, and it could be a mild cellulitis like infection localized, then it might extend proximally, or it can go through your body like systemic sepsis. You call it generalized infection. So initially, if there's a mild infection, we can treat with appropriate antibiotic and closely observe the wound whether it is responding nicely. And sometimes there could be a collection of infected material. We call it in medical term pus. So if there's we call it abscess also. So if there's an abscess, that is collection of pus inside your subcutaneous tissue, we put a small incision and drain all the pus out, and continue antibiotic and do a proper wound dressing, so the infection is controlled. That is the early stage. So generally, with the proper wound debridement, antibiotic, wound gets healed. The infection gets controlled first, then after 2 to 3 weeks, wound should get healed. And sometimes we get some patient, they have done a lot of wound debridement, antibiotic is given, but still wound is not healing. So as a clinician, we think there should be something underlying why this wound is not healing properly. Then we think about other causes, why this diabetic patient is having a poor healing ulcer. So when diabetes is poorly controlled, there's something called ischemia. That means lack of blood supply. Because of the diabetes, the blood vessel of the foot get narrowed or occluded. So there's no proper blood flow to the foot. Without proper blood flow, wound will not heal. So we can identify those patients by palpating their foot, whether there's a palpable pulse, or by looking at the external appearance of the wound. Someone can think, oh, this is a ischemic ulcer because lack of blood supply. In that case, without correcting the ischemia, that means lack of blood supply, the healing will be really difficult. So in that case, we have to do revascularization. That means we need to re-establish the blood flow by surgical means. It could be a minimal invasive method or open surgical method, or whatever the way, we need to re-establish the blood flow. Then only the wound start to heal. That is one condition, that's ischemia. Other thing, neuropathy induced ulcer. Sometimes you have a pressure area at your sole where the wound is not healing because this patient keep on walking on the wound and this wound is not going to heal. Then we properly assess those wounds and we shave around the wound. There's a thickened hardened skin, we have to remove those things, and then we tend to offload this area. So we ask them to wear proper footwear to offload that wound. So we keep them off the ground without applying any pressure of the wound. So that is we call it pressure also neuropathic ulcer. And sometimes they have had a lot of wound debridement done, but still wound is not healing. Sometimes it heals and sometimes it reappear again from some other point. Then we might consider there could be some bone particle inside which is infected. So you do all the dressing and antibiotic, but it doesn't reach the actual pathological organism. So in that case, we take X-rays and see what bones are involved. In that case, we need to remove that bone properly and then continue follow-up until wound get healed. That is how we approach in the beginning.
So it is quite a process.
Yeah, it is.
The treatment.
Yes.
And the more severe the condition is, it's I think much more difficult for the medical personnel to actually bring some relief to the patient.
Exactly, because when they come at early stage, we have a lot of armamentarium to treat this patient. So we can observe initially what is the main pathology, whether it's a neuropathy, ischemia, or diabetic immunopathy or something. There are a lot of explanation for this, but I'm just explaining in a simple way. So when patient come in initial stage, we can see how the wound progress. And if there's any lack of healing, then we have to address the main things. Whether it's a neuropathy, ischemia, or immunopathy, we have to address accordingly. If you, without addressing that, if you continue to treat, then wound get complicated. Then it is very difficult the clinician to control from there onward. But still we continue to manage, but it's always better. The prevention is better, then the early referral is better, then that is how it goes.
Doctor, we have heard of parts of the foot, maybe the toe to begin with. You said you start off with the toe amputation. But supposing the wound is, say, on the ankle, then the toes don't get affected, or how does that happen?
It depends. Usually, as I said before, the wound can appear anywhere in the foot. Usually, if the wound appear at ankle because of the trauma, we have to assess. There's a generalized assessment why this wound has appeared. It's because of diabetes, or it's ischemia, or it's a neuropathy, or sometimes you have a called venous ulcer in the diabetic patient, where as you mentioned, the ankle. So then the pathology might not be ischemia. It could be a varicose vein. Then we have to do a proper Doppler scan and see whether this is due to varicose vein. In that case, we can treat varicose vein and then treat the wound. But if it's a diabetic induced wound in the ankle area, so depending on the depth, we have to consider whether we need surgical debridement. Usually not, but general wound dressing principle will apply for those patients. Skin discoloration, in diabetic, when, as I said before, there are multiple pathophysiology why they get this skin. Generally, what diabetic patient will get, skin cracking and dry nails and loss of hair, those things because of the neuropathy. And because of that, they get the foot discoloration, and they also get the muscle wasting and abnormal posture of the bone and abnormal pressure area. So altogether, they have a higher risk of getting a wound because of the dryness, cracking, and the abnormal postures. That is how they are getting more prone to get ulcer.
Thank you, Doctor. So very interesting, and we hope that our listeners would have taken note of the content of this program as articulated by Dr. Gayan Bandara on diabetic ulcers. Just one more question, Doctor, because time is catching up with us. Yeah. Now, getting back to the amputation, you start off obviously small and it can extend. Yeah. What's the worst case scenario in a patient? An amputation, will the whole leg be amputated at any stage if need be, and therefore thereafter rather can the patient continue even to walk, say with crutches or an artificial limb? On the other hand, with one leg being affected, and you said it can also affect the next leg. Yeah. In such situations, Doctor, what's the worst case scenario? I don't want to sound morbid here, but it's good to know.
Yeah. So actually, it's good to know what can ultimately happen if you don't address your wounds in the early stage. So as you said, it starts with the toe amputation. It can go to major limb amputation. We call it below knee amputation, sometimes above knee amputation. Why don't we like the amputation? When you have an amputation, your mortality goes high. So because of the general pathophysiology and your extra workload to work and all that, if you have an amputated leg, the chances of you dying compared to non-amputated patient is high. That is why we try to prevent amputation. Their mobility is less, they are more chance to get infection and all that. That is why we always try to avoid amputation by identify early lesion. When you have an amputation in the one leg, there's a high chance that other one get amputated. We call them the precious limb. So if there's any lesion in that foot, we consider it very seriously, because we don't want both legs amputated in the same patient. So that is why as a nutshell is, if you have a tiny wound, it can lead to major limb amputation and death. So prevention and the early management of the wound is essential to prevent all of these complications. It's all preventable if you properly follow the proper pathway and proper diabetic control.
Thank you, Doctor. On that note of solid advice, we end this interesting discussion on diabetic ulcers. Thank you to Dr. Gayan Bandara, Consultant Vascular and Transplant Surgeon at the National Hospital of Sri Lanka, for being with us on the program and sharing your expert knowledge on this very important topic. Thank you, Doctor.
Thank you. Thank you for having me.
Thank you too to Inoka Gamage for technical assistance. I'm Fatima Razi Kada saying good night and looking forward to your company next Monday, same time on Views on Health.